Hi everybody, it's me Dr. Mohammad Kazafi. You are watching Dr. Mohammad Kazafi Views, and I want to present one very important topic which is called the intracranial pressure management and how we are managing the intracranial pressure. As you know, for analogy, I took one case which is a 29-year-old female pedestrian is hit by a car, and initial Glasgow coma scale was 6 after the resuscitation, and the CT scan is obtained, and it shows there is a small right acute subdural hematoma with the 4 millimeter midline shift. An intraventricular drain is placed to monitor the intracranial pressure. So I just want to discuss here, okay, what was the pathophysiology and what is the pathophysiology of this raised intracranial pressure. You know, there is a Monro-Kelly hypothesis states that the cranial compartment is incompressible, and the volume inside the cranium is a fixed volume. So according to the Monro-Kelly hypothesis or doctrine, we are following and we are understanding the intracranial pressure. So the cranium and its constituents, blood, cerebrospinal fluid, and the brain tissue create a state of we can say state of the volume equilibrium, and such that any increase in the volume of one of the cranial constituent must be compensated by the decrease in the volume of another. And a small increase in the brain volume do not lead to immediate rise in the intracranial pressure because of the compensatory measures such as the displacement of a CSF into the spinal canal and the stretching of the falx cerebri and the tentorium or tentorium cerebelli, and decrease in the venous blood volume. However, once the intracranial pressure goes beyond the compensatory phase, you know that the small increase in the brain volume or any other constituents can lead to marked elevation in the intracranial pressure. Once the intracranial pressure start to elevate, it affects the brain in two major ways. You know that the high intracranial pressure leads to decreased cerebral blood flow, and as can be observed by the following equation, such as the cerebral perfusion pressure is equal to the mean arterial pressure minus by the intracranial pressure. And then you found when you minus the mean arterial pressure from the intracranial pressure, then you will find the cerebral perfusion pressure. And the cerebral blood flow, you know that when you divide the cerebral perfusion pressure by the cerebral volume, so which shows you the cerebral blood flow. So you know the cerebral perfusion pressure and the mean arterial pressure and the cerebrovascular resistance all are very important in that regard to understand the different values of the different parameters of the pressure. Any increase in the intracranial pressure will decrease the cerebral perfusion pressure in the normal and physiological state, and the cerebral blood flow will remain constant because of the cerebral venous resistance or cerebral vascular resistance will vary to compensate, and this is called the autoregulation mechanism, and this compensation is impaired in the extreme of the pressure or in abnormal state, for example brain trauma. Once the intracranial pressure is high and compensated, the brain tissue will start shifting and herniating through the dural opening. The herniation will cause brain tissue compression and disturbance in the blood flow and damage to the vasculature, as well as further increase in the intracranial pressure. There are different types of the herniation. One is the uncal herniation. Uncal herniation is caused by a mass in the middle fossa that displays the uncus between the midbrain and tentorial edge, and this causes compensation on the descending tract and the reticular formation in the brain stem, causing a decrease in the level of consciousness and contralateral hemiparesis. The ipsilateral oculomotor nerve is also affected, causing ptosis and mydriasis. So sometimes the midbrain is squeezed against the contralateral tentorial edge or Carnot's notch, causing the ipsilateral hemiparesis. The posterior cerebral artery will be compressed, causing ischemia, and with more severe herniation, the basilar artery will be stretched and causing tearing of the brains. You can say brains perforating the vessels, and the brain stem infarction and the bleeding happen. So this is the durate hemorrhage, and we have to understand these things so we can explain in a better way. Here the question arises, how can a monitor the intracranial pressure? One of the most reliable method is the clinical picture of the patient. If the patient is awake enough to be followed clinically, and this can be used, and the objective parameter indicated that he is maintaining his perfusion and that his ICP is compensated. So once the clinical exam is lost for any reason, decreased level of consciousness, intoxication, or other parameter should be used. So that's why the several methods have been developed for measuring the intracranial pressure, and the classical method include intraventricular catheter placement, ventriculostomy, intraparenchymal monitoring, epidural devices, subdural subarachnoid device. So these are, or the bolt we can use, the subdural or subarachnoid device or bolts we can use to gauge the intracranial pressure. Epidural devices are there, intraparenchymal device, and the intraventricular catheter placement is the most popular one, which I have been encountered till now. And as I mentioned before, the herniations are happen where? At the uncle, there is the uncus herniation. The uncus herniation is called the uncle herniation, and the hematoma can cause this thing. Simultaneously, the Carnot's notch and is very, very, very important in that regard, and the Carnot's notch telling us how it developed, and it is also very, very important factor showing the pressure inside the brain. And as you know, the uncal herniation, because of the uncus, and when the uncal herniation happen, the third nerve also compression, posterior cerebral artery compression, and in some areas, these effects cannot be denied. Carnot's notch, as you know, it is in that area it make like a notch, and the posterior cerebral artery compression is also explainable through the tentorium or in that areas. So the ventricular catheter is the gold standard, and given that it is the most accurate method, and it is also therapeutic as well as diagnostic. And what are the indication for the intracranial pressure monitoring? The guidelines were revised by the Brain Trauma Foundation in 2007 are include that the patient with the severe injury, for example GCS less than 8, after resuscitation and with an abnormal CT scan, hematoma, contusion, edema, the patient with the severe injury such as the GCS less than 8 and the normal CT scan with 2 or more of the following. So, the patients above the age 40, unilateral or bilateral motor posturing and systolic blood pressure, if less than 40 mmHg. So these are the, I think, we can understand there is a indication for the intracranial pressure monitoring. I just want to repeat few things. We know that definitely patient with the severe injury, GCS less than 8 after resuscitation, and with the abnormal CT scan, hematoma, contusion, edema, definitely we have to monitor intracranial pressure. Simultaneously, abnormal CT scan with two or more of the following happen, such as the age is above the 40 and the unilateral or bilateral motor posturing, and the systolic blood pressure is less than 90. Even the CT scan is normal. So we have to check the intracranial pressure appropriately. Intracranial pressure monitoring is not routinely indicated in the mild or moderate brain tissue cases. However, the treating physician can choose to monitor intracranial pressure in certain conscious patient with abnormal CT scan finding. So, as you know, how can we manage an elevated intracranial pressure? So, I just want to describe in that manner that the first, or like that, the brain injury from trauma results from the primary injury from the first impact, and this type of the damage has no treatment other than you prevent it. If you couldn't prevent, then definitely you cannot avoid, or you cannot treat that. Other thing, secondary injury, which can be due to the intracranial causes such as expanding hematoma, contusion, and diffuse edema that lead to raise in the intracranial pressure. So, and in the same manner, systemic cause such as the hypotension, hypoxia, and the pyrexia that lead to mistake in the we say the metabolic demand and the blood flow. Same manner, therefore the treatment start at the scene by the preventing hypotension and hypoxia and adequate resuscitation and airway management, followed by the rapid transfer to the trauma center. And once the CT scan is done and the surgical mass lesion is ruled out, an intracranial monitor is inserted if indicated, and the goal of the treatment is to keep an adequate blood flow which will match the metabolic demand of the injured patient. To reach this goal, intracranial pressure should be kept below 20 mmHg, and the cerebral perfusion pressure should be between 50 to 70 mmHg. And first, second, and the third therapies have been devised for the intracranial treatment. So the first year therapy here, in my opinion, elevation of the head to the 30 degrees to enhance the venous outflow, and keep the neck straight and the venous outflow patent, and the ventilation to the normocarbia, means the partial pressure of the carbon dioxide between 35 to 40 mmHg to prevent cerebral vasodilatation, and the hyperventilation can be reduced intracranial pressure by causing cerebral vasoconstriction. On the other hand, this decrease in the cerebral blood flow can cause ischemia. Therefore, the use of hyperventilation as a prophylactic measure with partial pressure of carbon dioxide less than 25 mmHg is not recommended, especially in the early period after the trauma. Hyperventilation is only recommended as a temporary measure in the case of high intracranial pressure, and the other treatment start as with other monitoring tool for the cerebral blood flow. As you know, we avoid hyperthermia because it may lead to an increase in the metabolic rate, and acetaminophen and the cooling blanket can be used to achieve this goal. So now you understand this is the ventilation to the normocarbia to prevent the cerebral vasodilatation, and hyperventilation and can reduce intracranial pressure by causing cerebral vasoconstriction, and on the other end this decrease in the cerebral blood flow can cause ischemia. So you have to be we need normocarbia because we don't want ischemia, and therefore the use of the hyperventilation as a prophylactic measure with the partial pressure of less than 25 mg is not recommended, especially in the early period of trauma. Early period of trauma allows or tell us the hyperventilation is only recommended as a temporary measure in case of high intracranial pressure until other treatment are started to other. Just want to gain the time. If you reach, don't do anything extra which disturb the autoregulation mechanism further, and you will go in the dilemma, and avoid that dilemma. So that's why second tier therapy, agitation and the pain are two common cause of the elevated intracranial pressure. Thus the sedation and pain control present an effective treatment modality. Hyperosmolar treatment is used to decrease brain edema and subsequently the intracranial pressure. The hyperosmolar treatment will also help in the cerebral perfusion. Mannitol and hypertonic saline can be used as the osmotic therapy agent. Neuromuscular paralysis for maximal muscle relaxation and decreased muscle tone. CSF drainage from the intraventricular drain, and it is very important. So the second tier therapy, it is also very important because the agitation and pain are the two common cause of the elevated intracranial pressure. Sedation and pain control patient are effective treatment is effective treatment modality, and the hyperosmolar treatment is used to decrease the brain edema and subsequently decrease the intracranial pressure. But the hyperosmolar treatment will also help in the cerebral perfusion. Mannitol and hypertonic saline can be used as an osmotic therapy agent, but it is only effects is temporary, that, such like a hyperventilation. And you just provide when you are want to avoid the herniation before the surgery or this time. So once you are doing the surgery, then everything will be careful and judicious is very, very important. Neuromuscular paralysis for the maximal muscle relaxation and decreased muscle tone, it is also an important factor for the second tier therapy. CSF drainage from is the intraventricular drain is also very important for second tier therapy. And the third tier therapy, as you know, is reducing the ICP. However, it is not clear if this measure improves the outcome. There are no clear guidelines about the indication and timing. The only randomized clinical trial was done in the pediatric age group, and it shows the better outcome, but this is not reach statistically significance. Barbiturate coma, for example, high dose barbiturate therapy can result in the control of the intracranial pressure when all other medical and surgical treatment fails. And this effect is attributed mainly to decrease in the cellular metabolic rate and subsequent decrease in the cerebral blood flow. The main side effects are hemodynamic instability and lowering immunity. It has shown no clear benefit in improving outcome, and prophylactic use in the treatment of intracranial pressure is not recommended. So here I just want to explain you a little bit about this. I want to tell you about this little about according to the, as you know, according to the Monroe-Calorie theory, Monroe's Calorie theory, that the cranial compartment is incompressible and its contents, blood, cerebrospinal fluid, and the brain tissue are in internal milieu of the volume balance, and this is increase in one of the must offset by the reduction in the other component, and the intracranial pressure guide therapy has been the cornerstone in managing severe traumatic brain injury. Intracranial pressure monitoring allows for the judicious use of the intervention with the with the defined target point, thereby avoiding potentially harmful aggressive treatment. And as you know, there the participant get in the depth examination of the intracranial pressure guided therapy and emphasis its role in managing severe traumatic brain injury, and the course outlined current monitoring recommendation and covering invasive technique like the intraventricular catheter and non-invasive method like the transcranial Doppler ultrasound, and particular insight into the judicious intervention with a defined target point aimed to prevent potentially harmful aggressive treatment. And you know, the purpose of our topic is that the normal intracranial pressure, you know, there is a 7 to 15 mmHg, while it does not exceed more than 15 mmHg in the vertical position, and overnight sleep monitoring is considered the gold standard in conscious patient, and typically intracranial pressure lowering therapy initiate when pressure exceeds more than 20 to 25 mmHg, and the refractory elevated intracranial pressure reduce cerebral perfusion pressure and counting the cerebral ischemia and initiating the herniation syndrome, and then eventually lead to the death of the patient. So the implementing multi-modal monitoring and adherence to the intracranial pressure guided system has been cornerstone in managing the severe traumatic brain injury. So the intracranial monitoring allow for the judicious use of the intervention with a defined target point, and therefore avoiding potentially harmful aggressive treatment, and the Brain Trauma Foundation guideline during patient care bundle approach have shown to the positive outcome and minimize the cost of the acute care. Definitely, I present in front of you. This is what is the Monro-Kelly theory, and you know the historical prospect here. The Alexander Monro mentioned this theory in 1783 and a monograph that the brain tissue and the blood volume remained constant, and emphasized the necessity to egress the blood equal to any foreign liquid injected into the skull. So this George Kelly reinforced the assumption that the total amount of the blood flowing within the skull remains constant. And this John was primarily responsible for propagating this doctrine across the medical wards. However, they need more information about the anatomy and the physiology of the nervous system during that period to finish the hypothesis. So the disregarding the CSF involvement, if not this mere existence, the intracranial pressure control, and his book on the disorder of the cerebral circulation was popular and accepted in a huge way. Then Harvey Cushing established the doctrine, clinical and the physiological significance in the 20th century by confirming the Burroughs finding of cerebrospinal fluid role in the intracranial dynamic and existence of the three volumes that operate the compensator for volume depletion or insertion inside the skull. Terry Jenny published these hypothesis, or you can say the theory regarding the intracranial pressure monitoring, while the Lundberg present is more than 60 years ago, and the Jenny used the YouTube manometry to measure the intracranial pressure in 1951. So since then, now in the lumbar CSF pressure through the lumbar puncture in 1981, and now we are doing the different kind of the modern way of the monitoring of the intracranial pressure. Role of the doctrine in the intracranial hypertension or the role of doctrine in the intracranial hypotension are a little bit different, but here I just want to that there's some limitation for this doctrine. There is not mentioned the role of CSF in the brain adaptive physiology, and there is no mention of the effect of the gravitation of the volume and pressure inside the skull, and there is no application for children with the open fontanelle. So these are the few things they are showing the limitation of this theory, but definitely this theory help us to understand a lot of things. You know the interaction between the cerebral volume and intracranial pressure. You know cerebral compliance is the volume required to produce a specific change in the pressure, and thus cerebral compliance may be defined as the cranial vault adaptive ability to increase volume, and the cerebral elastance and the pressure resulting from the known change in the volume, it interpreted as a opposition of intracranial volume growth. The pressure volume curve is divided into three phases. Initial phase, phase 1, the stage is characterized by high level of the brain compliance and low ICP, and despite the volume rise, there is no evidence of the subsequent increase in the intracranial pressure, but the cerebral blood flow and the cerebral blood volume nullify the increase in the volume. This is called the initial stage or phase 1. The transitional stage, phase 2, this stage is characterized by the poor brain compliance and the low intracranial pressure, although the later gradually increase. And the third phase or the ascending stage, this stage exhibit poor or non-existent compliance with the elevated intracranial pressure, and which is beginning of the decompensation and compensatory, and a process become inactive and the tiny volume change result in significant intracranial pressure. So these are the things which are showing that total whole scenario regarding the intracranial pressure. You know the Brain Trauma Foundation guideline for the traumatic brain injury management level 2 recommendation is that an intracranial pressure monitoring is recommended in the following situation, such as patient with the Glasgow Coma scale score of less than 8, an abnormal computerized tomogram scan of the head. 2 or more of the following are present, such as the patient's age if more than 40, and the unilateral or bilateral motor posturing, or the systolic blood pressure less than 90 mmHg. These are the indication. And the other indication also, patient with the initial normal CT scan with the minor changes in the CT images, but the later show features of the neurological worsening or the progression on the repeat. It's also the indication for intracranial pressure monitoring. Evidence of the brain swelling, compressed or absent basal cistern, patient with the extensive bifrontal contusion independent of the neurological condition, and when sedation interruption to check neurological function is not justified, so the respiratory failure from the lungs contusion and the flail chest, and when the neurological examination is not reliable, so the maxillofacial trauma or the spinal cord injury are there. A decompressive craniotomy is performed as a result of the intracranial hypertension refractory to the medical management. And following craniotomy, where there is a relevant risk factor for the propagation of the brain edema, for example, confounding hypoxemia, hypotension, pupillary abnormalities, midline shift greater than 5 millimeters, and the contraindication, you must know that the concurrent use of the anticoagulant drugs is contraindicated, bleeding disorder contraindicated, scalp infection contraindicated, brain abscess contraindicated, and equipment, you know the basic equipment is you use the non-sterile glove or the soap, brush, hand towel, razor, and the marker pen for the parts preparation and making of the site of the placement for monitoring device, and for the procedure a face mask, sterile gown, gloves on the antiseptic solution, a drape, local anesthetic agent, and a 5 ml syringe, a number of 11 or 15 surgical blade, and the intracranial pressure monitoring kit, drill with the drill bit, and the bolt with the intracranial pressure sensor, and the transducer per the method utilized, and the suture material and the sterile dressing. To monitor the intracranial pressure, use intraventricular monitoring with ventriculostomy, intraparenchymal strain gauge, and the fiber optic monitor. Therefore, it is essential to have the appropriate monitoring device readily available with us. And the person, usually the surgeon, the qualified assistant, attending nurse, and the anesthetist. As you know, the preparation before any medical medical procedure for the patient, or either medical proxy should be comprehensive, explain the reason for the procedure and the potential risk. So the additionally obtain written consent, strict adherence to the aseptic guideline in the cornerstone in preventing infection, and prophylactic antibiotic must be administered at the beginning of the procedure, and the meticulous technique is vital in the minimizing procedure related complication, and the patient should be well and sedated, assuring patency of the airway, and the local anesthetic should be administered at the allocated point of the ventriculostomy or insertion of the intracranial pressure monitoring device. Simultaneously, technique or the treatment, the placement of either a burr hole or the twisted drill technique at insertion of the device. So the Cocker's point is the choice of the ventriculostomy, which is 3 cm lateral of the midline and 1 cm anterior to the coronal suture, and other points of the ventricular puncture include the Keen's, Dundee, and the Frazier point. And once the hole in the skull is made, the monitor is placed in the lateral ventricle, and as the pressure and the pulse amplitude of the intracranial pressure waveform is favored rather than its assessment from the height of the cerebrospinal fluid volume. The pulse component of the waveform shows the following 3 peaks: P1, which is the percussion wave due to the arterial pulsation; P2, there is a tidal wave represent with the brain compliance; and the dichotic wave owing to the aortic valve closure. So these 3 waves, with P1, P2, and P3, I already explained in front of you, and that there is some complication of the ventricular catheter-based intracranial pressure monitoring. It is the intracranial and tract hemorrhage. This is 10%. Infection, ventriculitis is 20%. And a technical failure is about 5%. Failure to the tap, ventricle, and over drainage can lead to the aneurysmal rebleeding and complying the upward transitional herniation in case of the hydrocephalus. Kink and the blockage by air, blood, and debris are present also, and there may be localized elevation of intracranial pressure due to the compartment size from the mass lesion. So I just present in front of you the different ways, and we have types of the intracranial pressure monitoring system. One is the fiber optic, which is called the Integra. The other is a strain gauge, which is called Codman, and the third one is pneumatic, which is the Spingelberg. So the monitor is variable. That the implantable intracerebral sensor in parenchyma, in subdural, in epidural. Epidural has a very low sensitivity. Subdural applied in conjunction with craniotomy, and parenchymal, the reading are based on the zero drift of the sensor following pre-insertion, zeroing against the atmospheric pressure, and possible limitation include placement dependent reading. So the drift in the zero difference vessels, blood, and the infection are also important. Intracranial pressure monitoring fluid based, which is very popular, and I also prefer for that too much. This is called the ventricular catheter, and the foramen of Monroe is mainly used to reference of the zero level, and frequent zeroing is imperative. There is an inherent risk of the misplacement, hemorrhage, and the infection. Intracranial pressure source signal are also prone to the inaccuracies owing to the air bulb, debris movement, and the kink. So that the monitoring and variables are also there. Cerebral perfusion pressure is the most widely followed surveillance module. A correlation coefficient R between the amplitude and pressure and index with the more than 0.6 is indicative for the impaired pressure volume reserve. Pressure reactivity index, and monitoring indices, and we can say the intracranial pressure waveform, respiratory waveform, pulse pressure waveform. There are 2 kinds. The percussion wave is because of the arterial pulsation, and the tidal wave because of the intracranial compliance, and the third one is the dichotic wave, and the vasogenic wave, which is the Lundberg A and B. There is the Mayer's wave also. So there is a lot of detail in that regard, but I must think there is some knowledge already we discussed, and I hope we understand the monitoring and some kind of management, intracranial pressure management here. But definitely the similar kind of topic could come in future. I hope you will like it, share it, and subscribe it. Thank you so much.